Part A. In this part of the test, you'll hear two different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1.
Hello, Rebecca. How are you today?
Dr. Miller, I'm still having problems holding my urine until I get to the bathroom. I'm leaking before I can make it to the toilet, so I've been wearing these bulky pads. I have to wear them. My desk is at the other end of the office, far from the bathroom.
I see. Well, the last visit you said that you are not leaking urine when you cough, sneeze, exercise, or lift something. Has that changed?
No, I don't leak at those times. I'm just feeling this urgency to go and rushing off to the bathroom 10 or 12 times a day. It's a nuisance because I'm so busy at work these days.
Well, we've ruled out bladder infection and other bladder problems. It seems that you have a type of urinary incontinence called urge incontinence. It affects women across all age groups. Likely the muscles that you use to hold your urine are weak. Well, the good news is that there are treatments that work to help you to become continent.
Continent?
Continent, being able to hold your urine until you go to the bathroom. And even if you aren't continent 100% of the time, treatment can mean fewer times when you leak urine by accident.
That would be nice. How is this treated?
Well, there are quite a few non-surgical treatments for urge incontinence. Some lifestyle or non-drug treatments include bladder training or a medical device called percutaneous tibial nerve stimulation. Then there are medications.
There are a lot of choices. Could you go over the options?
Sure. With the bladder training, you hold your urine for longer and longer amounts of time.
I see.
With nerve stimulation, a thin needle is inserted near your ankle. Pulses of electricity stimulate the nerves in your leg that connect to the nerves that control your bladder muscles. And prescription medications can reduce your incontinence or eradicate it completely.
It's a lot of choices. I'm just not sure. What do you think I should do, doctor?
Rebecca, people with urge incontinence get results from all the treatments I just mentioned. But since you're busy at work and the bathroom is so far from your desk, for now, I'm going to prescribe a medication to help you with this problem.
A prescription? Well, I guess I could give that a try.
Now, I want to see you back here in about a month. Call me sooner if you're experiencing side effects from the medicines or finding that you want to do something else. I think we can get this thing worked out for you.
Extract 2, questions 13 to 24. You hear an occupational therapist talking to a patient, Miguel Castillo. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Come on in and have a seat, Mr. Castillo. Make yourself comfortable.
Thank you, sir.
You're welcome. Before we start, I'd like to check a few details with you if I can. Your date of birth, please.
18th September, 1981. And I know what you're thinking. Yes, I'm a typical Virgo. Headstrong and resourceful.
All right. What do you do, Mr. Castillo?
Mr. Castillo is what my bankers and lawyers call me. You can call me Miggy, and I'm a bouncer for Voga Clubs Limited. They're the ones who arranged this session for me on account of my alcohol misuse.
And do you have problems with alcohol?
I don't think I do, but I bet you knew I was going to say that, right? If you ask me, my boss's concerns are misplaced. They should be way more worried about the anxiety I've had since late 2017 than this. At least that was medically diagnosed.
I don't think they'd be concerned for no reason.
No, I guess not. I've been hitting the bottle a lot recently, and I guess it's getting more and more difficult for me to hide it. I have these episodes. I go hard at it for a good few bottles, and I think all that concentrated spirits intakes, it's wreaking real havoc on my gut. You've got to understand, though, I'm surrounded by this stuff every single night. I'd not give a flying fig about Voga's concerns if it wasn't for my family. It's the effect on my responsibilities as a papa that brought me here, not Voga's pretense that they give a...
The head of HR called Miggy. I think they care, and you should give them credit for that. You mentioned your family. How long have you been married?
I'm not. I've been with my partner for 10 years, but I never married her. We've just had a little boy together. He turned 1.5 yesterday, and I love him more than I ever thought possible. Even if he looks nothing like me and everything like his mother.
Congratulations to you both. So, back to your employer's concerns. Was it just the drinking?
No, they ranked me over the coals for timekeeping. I can't remember the last time I turned up to a shift on time. It's caused a few rows between me and my immediate supervisor. In fact, the last time got a bit violent. Management's used to the bouncers getting a little aggro from time to time. But I guess they draw the line at violence towards clients.
So there's blows between you and colleagues and customers. Miggy, you know this can't continue. First, we've got to work on breaking the dependency. I spoke with your HR at length, and they've agreed to give you time off so that you can work on yourself. In specific, we're going to go over some coping strategies, which we'll create and rehearse so that you don't have to turn to liquor. There are 2 types of therapy that we use here, and I think that the one that suits you requires us analyzing when you have these episodes, what triggers it. This is called the diagnostic model.
I like the sound of that. I'm keen to get to the root cause of my problems.
Good. Our previous results are very strong. In fact, we've had a 200% success rate that we're very proud of. We'd love to help you too.
That is the end of Part A. You now have 2 minutes to check your work.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen.
You hear a physician talking to a group of trainee doctors. Now, read the question.
Honeybees have barbed stingers that are left behind in the person's skin after the initial sting. If the stinger is removed by pinching the stinger, more venom is actually injected, so it's better to remove the stinger by gently lifting it using a pair of tweezers to remove it from the skin. Generally, honeybees aren't aggressive and only sting in self-defense. However, in some cases, a person will disrupt a hive or swarm of bees and get stung multiple times. If a person gets stung more than a dozen times, the accumulation of venom may induce a toxic reaction and make them feel quite sick. And multiple stings can be a medical emergency, especially in children, older adults, and people who have heart or breathing problems. So make sure to check with the patient and be aware of the signs of multiple stings.
Listening Part B. You hear 2 dentists discussing a patient. Now read the question.
I've just seen Mr. Butler, one of your regular patients. He's been in some pain recently.
Right. I've been fully booked for the past few weeks, and he told reception he couldn't wait any longer. He's had chronic periodontitis for some time now, but I gather it's worse.
Yes, I provided thorough curative treatment in all quadrants today, but his gums were in such poor condition and there was severe mobility in his lower right first and second molars, so I had to extract them. I've scheduled him for implant surgery, but I'm worried about his broader health issues and whether or not he's been taking biphosphonates. I couldn't find any information in his records about it.
There isn't any, no. You may have to contact his GP.
Okay, I certainly want to reduce the risk of any osteonecrosis after surgery. Listening Part B. You hear an optometrist giving a presentation to a group of teachers. Now, read the question.
About 1 in 12 boys is colourblind, and 1 in every 400 girls. So in each school class there are likely to be at least 1 or 2 students who are colourblind. Because they are colourblind from birth, most people don't know that they're colourblind. They don't know that other people see things differently. Being colourblind can cause difficulties when it's important to be able to see lots of colours, such as on a computer screen or in art classes. Boys should have their colour vision tested when other people in the family are known to have colour vision problems. If people on both sides of the family are known to have colour vision problems, then girls should also be tested. Colour vision testing can be done by optometrists using specially designed charts. Some school health services and some doctors will also be able to test colour vision.
Listening Part B. You hear a radiographer talking to a patient about their CTC examination. Now, read the question.
Okay, so your appointment's scheduled for 8:30 next Tuesday morning.
That's great. Thanks for organising that.
No problem. Now, the main purpose of the CTC examination is to look for abnormalities or polyps in the large bowel with the use of a CT scanner. So that means 3 days before the test, you'll need to start eating a low-fibre diet, and then 24 hours before the test, you'll be drinking clear fluids and you'll need to abstain from alcohol. Then on the evening before the test, you'll need to take laxatives as prescribed by your doctor with several glasses of water. You also can't have any breakfast on the morning of the test, and we'll need you to be self-administering some suppositories at that time. But all of this information is set out in the letter. If you've got any questions or concerns about it, make sure you contact either myself or your doctor.
Okay, thanks.
Listening Part B. You hear a physiotherapist speaking to a support group for Parkinson's disease. Now, read the question.
The physiotherapist's aim is to maximise the patient's functional ability and quality of life. Physiotherapy can help alleviate symptoms like tremors, rigidity, slowness of movement, and impaired balance, which can cause abnormal gait and posture. It can also help with cramps and pain in the muscles, and even help patients who experience reduced fine motor coordination. Physiotherapists use physical treatments such as exercise to prevent or reduce stiffness in the joints and to restore muscle strength and mobility. As well as this, physiotherapists can supervise the patient's exercises to help maintain their posture and balance and advise the patient about ways of preventing or reducing the risk of falls. Physiotherapists use other treatments such as heat and cold or electrical equipment like ultrasound to help relieve pain patients may have. They can also advise or train parents and guardians of patients suffering from Parkinson's disease in safe and appropriate ways of helping them with mobility problems.
Listening Part B. You hear an oncologist talking with a patient about their test results. Now, read the question.
Well, I'm happy to report that the colonoscopy has found no evidence of cancer.
Are you sure, Doctor?
I know you're worried because your father had bowel cancer, but your test came back negative, so that's a good result for you. And let me reassure you, we can see cancer if it's present in the colon in more than 90% of cases. So we miss very few early stage cases.
That's a relief, Doctor. It really is. But then we still don't know why I'm experiencing these abdominal pains.
Actually, we do. We discovered that you have something called diverticular disease. Have you ever heard of this condition?
No, I haven't, but it sounds pretty serious.
Well, if we follow the proper management, it doesn't have to be so serious. Let me tell you a little bit more about it.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Extract 1. Questions 31 to 36. You will hear an interview with a sports injury specialist called Toby Walsh on the subject of hamstring injuries. You now have 90 seconds to read questions 31 to 36.
My guest today is a sports injury specialist called Toby Walsh. We're going to be talking about hamstring injuries. Toby, hamstring injuries are something sports people at all levels of ability fear getting. Why is this?
Well, you're right. Hamstrings are the most significant injury in a number of team sports, including football and rugby, but any sports person could be affected. I think, looking at the statistics, hamstring injuries account for the largest number of lost playing hours amongst professional footballers, even though the average injury only takes about 3 weeks to heal. More worrying for the individual is that once they've had such an injury, the chance of sustaining another one in the same season is as high as 20%, so it can become the thorn in the player's side. That, I think, accounts for the reputation the injury has.
So is this an injury that can affect any of us at any time?
Well, the hamstrings are a group of muscles in the thigh that allow us to bend our legs and knees effectively. Now, some ethnic groups are more predisposed to these injuries than others, and everyone's chance of tearing the muscle increases with age. But apart from that, they're generally the result of short bursts of movement, like sprinting or suddenly changing direction. And they happen more in certain sports because these are just the sort of movements that players are making. They happen most often at the end of what we call the swing phase of running, just before the outstretched leg hits the ground and the muscles contract to bend the knee.
But I'm sure there are ways to prevent these injuries.
Well, looking after the muscles themselves obviously helps here. You can do various exercises that actually strengthen the hamstrings and so make them less prone to injury. And of course, warming up before exercise is crucial in avoiding all sorts of muscle strains, and sports people know that. But that isn't the whole story. One interesting finding is that a lot of people who develop hamstring injuries have coexisting back problems, and there would seem to be a correlation. By loosening up the lower back, you also help the nerves that control the hamstring. Flexibility there allows the muscles to function as they should, and there are exercises people can do to help that.
And is the risk of hamstring injury something that should be taken into account in training programmes?
Well, yes. Intensive training, of the sort you do for team sports like football, can put quite a heavy workload on the gluteal muscles, which can lead to a tightening around the hips, creating knots known as trigger points. These, in turn, can cause referred pain in the hamstring, reducing flexibility and increasing the risk of straining or tearing it. I mean, basic stretching exercises can help here, but also we know that muscles are more likely to strain if they're fatigued. Often, during a period of intensive training, you get cumulative fatigue. This can creep up on an athlete, on their muscular system over a number of weeks as the training intensifies.
And if an athlete does pull a hamstring, how can the sports injury specialist help?
Well, they'll feel the pain, maybe even feel a pop, and they won't be able to continue because the muscle will go into cramp and spasm. There are 3 degrees of severity, and the treatment will vary according to that. Fortunately, as a sports injury specialist, you're often present when the injury occurs, or you can see it on video, so you don't have to rely on a verbal account of symptoms to assess the severity. Initially, you want to stop any swelling as soon as possible. That's your priority. You're going to apply compression bandages and possibly ice. Although there's some debate about that these days, it does ease the discomfort. And you'll certainly elevate the leg and make sure the patient rests up.
And how long will the athlete be out of action?
Well, as I say, that's going to depend on the severity of the injury. They'll have to rest up for 72 hours, whatever happens, to avoid causing further damage. And things like heat and massage can be just as damaging as movement itself.
Oh.
A grade 3 injury can take months to heal and can be career-threatening for top athletes. What's more, lack of use can lead to the development of scar tissue and muscle shrinkage. In other words, the muscles won't return to their former state, even if the tear or strain itself heals. So part of my job is to ensure that doesn't happen by getting the muscles working again in the right way as soon as possible.
Now look at Extract 2, questions 37 to 42. You hear the discussion of a physician with junior doctors on different types of hernias. You have 90 seconds to read questions 37 to 42.
Hello, doctor. Could you please explain to us about different types of hernias?
Well, inguinal hernias are located in the lower abdomen just above the leg crease, adjacent or near the pubic region. At times, they can also occur on both sides of the pubic area, which is called bilateral inguinal hernias. Inguinal hernias, along with femoral hernias, make up the two types of groin hernias and can cause pain that extends into the upper thigh or scrotum. Inguinal hernias can be categorized as direct or indirect. An indirect inguinal hernia occurs due to natural weakness in the internal inguinal ring, while a direct inguinal hernia caused due to the weakness in the floor of the inguinal canal and is more likely to develop in men above 40. The floor of the inguinal canal is located just below the internal inguinal ring. When inguinal hernias are repaired using the tension repair technique, recurrence rates may be more than 15%. However, other techniques used for hernia repair, such as tension-free and laparoscopic tension-free, have much lower recurrence rates of just 1%. A sportsman's hernia is a condition of chronic exercise-related suprainguinal groin pain. Generally, it involves a direct inguinal hernia. Femoral hernias, along with inguinal hernias, are groin hernias, which are very common in women but can occur in men as well. A weakness in the lower groin makes the intestinal sac to drop into the femoral canal, a space near the femoral vein that carries blood from the leg. These hernias are highly prone to develop incarceration or strangulation as an early complication. Incisional hernias appears in the abdomen at the site of a previous surgery that can appear weeks, months, or even years after a surgery and can vary in size from small to very large and complex. Umbilical hernias appear near the belly button or navel due to a common weakness from the blood vessels of the umbilical cord. This may occur in infants at or just after birth and may resolve by 3 or 4 years of age. However, in adults, umbilical hernias will not resolve and may progressively worsen over time. Epigastric hernias are more common in men than women. They occur due to a weakness or opening in the muscles or tendons of the upper abdominal wall on a line between the breastbone and the navel or umbilicus. Spigalian hernias, a protrusion of intestine or an empty sac through a weakness between the muscle fibers of the abdominal wall, often on the right-hand side of the abdomen. It becomes impossible to detect because often there is no obvious swelling or lump. It develops between the muscles of the abdominal wall rather than protruding through layers of fat. It often develops in later life of men and women when the abdominal muscles become weaker. Hiatal hernias are slightly different from other types of hernias because they are a weakness or opening in the diaphragm that separates the chest cavity from the abdominal cavity. These hernias cause reflux of acid from the stomach into the esophagus, resulting in heartburn, pain, and erosion of the esophagus.